I'm sorry. Thank you. After the tone, state your name, followed by the pound or hash sign. Thank you. You will now be placed into conference. To mute your line, press *6. To unmute, press #6.
I'm going to ask those people who are on the line to please mute your phones. Thank you. Thank you. Okay, for anybody who doesn't have mute, if you push *6, that will mute your phone. #6 will unmute. Good morning to those of you that are joining us.
Good morning.
Good morning. Good morning. Anyone coming on? We're asking you to please mute your phone once you're on. Hello. Welcome.
Hi.
Hello. We're asking folks as they join to mute their phones. *6.
Okay, and then to unmute is six star?
#6 is unmute.
Okay, let me write that down.
Hi, this is Santa Fe County. We're still trying to log in. We're having difficulty getting to the webcast. Is everybody else on board, or are there any technical difficulties that you know of?
Not that we know of. We're still waiting for everyone to dial in, and we're asking that folks mute their phones as they come on.
Okay, thank you. Say one more time, I'm sorry.
Okay, I have a question. Did you test your system before?
For me, Southern Family Center? Yes, I just had an IT person in here, so the website that I got up says the title of the course.
Yes. Yes. Okay, so then if you'll mute, that would be good.
And it's *6 to mute, #6 to unmute?
Correct.
Thank you.
Thank you. Welcome to anybody new who has joined us. You should be seeing on your screen the first page announcing the webcast. And we're asking you as you join in to please mute your phones at *6. Somebody
asking for a meeting key.
That should be in your email announcing the conference.
Well, it says name, meeting ID, and then meeting key is required, and then join meeting. And
did you click on the link?
Yes.
Yeah.
First one was says live meetings and groups.
Are you in?
No.
Okay. I'm going to have our technical person talk to you. Who's do we talk to? Figure it out.
Oh, maybe others.
Is somebody still having difficulty joining live meetings?
I just got a quick question.
What's that?
How do I get, so is there like something I'm supposed to be seeing as far as a person talking, or they're just supposed to be seeing the slideshow?
Yeah, no, you'll just be seeing the slideshow, and then the audio portion will be via the conference call.
Okay, awesome.
Okay?
Hello. This is Vincent Giordano. Can you hear me?
Yes.
Oh, okay. Yeah, are the slides going to change by you?
Yes.
Oh, okay. Then I'm just going to hang up with the speakerphone on there and the mute.
Okay, great. Was there somebody else who's having trouble getting into live meetings?
I'm not sure where it is on the website in terms of looking at or do I just go through my own PowerPoint that you emailed me?
No, what you do is there's an email sent out and it has links. It says click here to join.
It was sent to you yesterday?
Yeah, I have the email. I don't see the link.
It's in blue.
Live meeting, click on that.
I see CIMH.org that's under Maria Lovato's.
Maybe scroll up a little bit. Did you send out that PowerPoint separately, didn't you?
Yes.
Yeah, the PowerPoint was sent out separately, so there should be another.
Oh, I don't have the email then. Unless this is it here. Nope.
Hi, this is Stanislaus County. Can you hear me?
Yes.
Okay. We're still having difficulty connecting. We connected to live meetings, but the slide that comes up says, "Have you successfully connected to live meeting?" So we're having difficulty.
It says you have connected?
Yes. Yes. Well, it says to connect. You have successfully connected to live meeting, but that's the only slide that we see. Is that what's up on the screen?
No, it might be taking a little while to process or something.
Okay, we have our IT tech person here working on it.
All right. I think at this point we need to ask everyone to go to mute, and we'll start with the presentation. And those of you that are having technical difficulties, if you can't get in or get it straight, we'll have this. This is being recorded, so it'll be available to you. So we're going to get going. Looks like we have just about everybody with us. And once again, I'm going to remind you, *6 to mute, #6 to unmute. So good morning. It's Mary Jane Alumbaugh here, and welcome. This is a huge PowerPoint and a big presentation. So I'm probably going to talk a lot faster than you like, and I'm probably going to skip some material in order to try and get through this. We're going to ask that folks hold their questions to the last 15 minutes. And what probably works the best is if you email questions to Maria Lovato as we go through the presentation, and then at the end we'll hopefully be able to answer most of them. For those of you that have never done a webcast, we'll be going through the PowerPoint. We'll change the slides at our end. The audio is through the conference call line. I think that this works best if you move to a full screen view. So if you'll go to View, press View, and then press full screen, that should make it a little easier for you to see it. All right. So let me get going here. Thank you very much. We've had tremendous interest in this webcast, and that's very gratifying because this is a really significant area of difficulty, service difficulties. We're going to have the PowerPoint. And then we have 2 attachments which will be available to you. The attachments will be further information in terms of assessment instruments, some further slides or graphs about data, and hopefully, if it came through, a copy of a short-form assessment instrument called the GAIN. All of our information will be posted on our website, the PowerPoint, the attachments, and a longer outline that contains more information. Okay, so having said that, a couple of limitations I want to point out. As we were putting this together, we came across a lot of treatments, and we had to winnow it down. Everything that we're going to present to you is evidence-based, empirically grounded data. There were some treatments that were or are effective with transition-age youth, and because of time limitations, we had to take them out of the presentation. However, those treatments will be in the longer outline that will be on the web. Okay. Let's get going then. Okay. So we'll go through the research briefly because there's a lot of research and we can't cover it all. We'll go through briefly some systems issues, briefly some of the assessments, and then we'll move to the treatments. And at the end, we have some recommendations about some treatments that we think you might want to take a look at. And then we'll open for questions. Okay? So let's talk just a wee bit about the research. I'm sure you all know this quite well, so I won't belabor the point. So the research tells us that the majority of kids coming into substance abuse treatment have a co-occurring mental disorder as well. Now, it also works the other way. The kids that we're seeing in the system of care system with mental health problems, at least one-fifth of them have a co-occurring disorder. As I'm sure you all know, the kids, the youth that we're seeing with the co-occurring disorders are more difficult to treat. They have poor treatment outcomes, both in terms of physical and psychological difficulties. And of course, the big issue with treating youth and substance abuse is the effects that drug abuse has on the brain. There's clear evidence now that in terms of the chicken or the egg, which came first, the substance abuse or the psychiatric difficulty, emotional disorder, the symptoms appear first. Sometimes many years before, but research is saying at least a year previous to substance abuse disorder onset, there are psychiatric, emotional, behavioral symptoms present. To me, this is a really big issue. I don't know about you folks, but I cannot tell you how many adults I have seen in treatment who have said, well, I was doing okay until I started doing meth when I was 16. Or I started doing da-da-da-da-da when I was 14. And attributing the serious psychiatric disorder to drugs when, in fact, the symptoms were emerging earlier. And it was the substance abuse disorder that probably was an attempt at medication. Again, I'm sure you know this better than I do. Just an idea to give you the incidence. At the CSAC site, Centers for Substance Abuse Treatment, 74% of these youth have a co-occurring mental disorder. That's a huge number. At our system of care sites, 21%, almost 22, had 5 or more presenting problems, at least one of which is a substance abuse disorder. That's a lot of kids. Substance abuse co-occurring disorders are categorized into two broad types, internalizing and externalizing. You can see that the externalizing is a much more predominant presentation. But you know there are a lot of kids that present with symptoms from both types, and 38 to 65%. Okay. Those kids that you're seeing with ODD, oppositional defiant, conduct disorder, disruptive disorders, ADHD, and depression and or anxiety, just depression, are associated with an early onset of substance abuse. Again, that goes back to which came first, the substance abuse or the symptoms. The symptoms. That's pretty clear now. Now, this is something that I think is an important issue for us as clinicians to think about. These kids that are coming in with substance abuse disorders have huge rates of trauma and victimization. 25% of the boys, males, 75% of females. And the victimization ranges from physical abuse, sexual abuse, living in chaotic homes, the trauma that comes from living in poverty. Next slide. Again, this is something you both know. You all know that both disorders are often seen in boys and girls. The interesting thing is that girls who come into treatment with a combination of conduct disorder and substance abuse seem to be much more it seems to be much more serious, much more disordered. Now that could be a function of the fact that girls don't get diagnosed early in the treatment or in the trajectory. That often girls don't show up in, and this is primarily probation settings, often don't show up until they are really beyond the pale in terms of how much trouble they're getting in. But it's very clear that the girls, females with a substance use disorder and behavioral problems present as much more disordered than the boys. Girls also present with much more of the internalizing disorders and externalizing, 83% to 41%. And in terms of poor outcomes, girls are overrepresented. The interesting thing, I talked about the trauma before. The interesting thing, worrisome thing I think about this issue is that females, the girls, report a significantly higher level of drug dependence versus drug abuse. That's a huge difference. And again, a focus for treatment. And I meant to say, with the internalizing and the externalizing disorders, if you're able to sort out which kind of co-occurring disorder you're working with, that gives you a treatment target. Okay. Boys, and I'm sure you know this better than I do, more often present with behavior problems, disruptive disorders. Most of the referrals for boys come from the juvenile justice setting. And in juvenile justice, 75% of the boys and 50% of the females have a co-occurring disorder. That's a lot. That's a lot. But again, you know this better than I do. Next slide. So I kind of whizzed through the research. There's a lot more there. We weren't able to, we had to pare a lot of it down. I think if there's anything to take away from the research, the issue that adolescents with substance abuse disorders are at 6 times the risk of having a co-occurring psychiatric disorder. The psychiatric disorder presents first. And if you're able to intervene intervene early, the substance abuse disorder will not be as severe. And young people at risk have significantly higher lifetime incidence of substance abuse. And I guess the next main point is is the differential outcomes and illness trajectory for girls. All right, let's go real quickly to some of the issues. And you know, I know that those of you who are out there in the trenches know this better than I do. The difficulty with the 2 different kinds of systems. I think the primary issue in terms of systems issues for co-occurring disorders is that these kids are right at the nexus of where these 2 cultures clash, the substance abuse treatment system and the mental health treatment. I'm going to go, you all, just mental health treatment, medical model, emphasis on licensure, and the primary issue here, often treatment, at least used to be that often treatment could not begin until abstinence is obtained. So kind of to come back in 6 months when you're clean. Next slide. Again, and there's often a reluctance to medicate individuals with a substance use disorder, understandably, because it's a huge issue in terms of, are you going to give medication to this child or this adolescent who is drinking and doing drugs and have them easily overdose. It's an issue that has to be addressed and can be very fraught with peril. Often in the mental health system, the mental health treatments are provided, but the substance abuse disorder is not addressed, is put on the back burner, as it were. And in a sense as well, you know, I need to treat this mental health disorder, substance abuse will come along later. The facts are that treating one disorder does not necessarily improve the other disorder. both have to be treated, and both have to be treated as primary disorders. Next slide. In the substance abuse treatment model, as you all know, often licensure is not necessary, although this is changing significantly. And there's a difference in terms of the provider's stance. Often the provider is a recovering individual and able to openly disclose that and talk about it. And in the peer relationship model, this is seen as giving the treatment provider the status of an expert, someone who knows the issues. And then too, as you know, many substance abuse treatment providers have the philosophy that absolutely no medication of any kind can be taken, not even an aspirin, because it's a drug. This can present as a barrier, clearly. Okay. And the same thing, often in the substance abuse treatment model, the mental health problems are not addressed. Perhaps the provider is not cross-trained or doesn't know mental health issues, and vice versa. Both of these issues go both ways between both systems. And often individuals with a substance use disorder don't talk about it because they're focusing on the substance abuse, and they're not focusing on the mental health problem. That's just a small part of the systems issues, and I didn't even address the funding and the Medi-Cal regulations and all of the day-to-day nuts and bolts issues that make it difficult. I think the issue for all of us is how to get the best from both of these systems, or how to combine them, what to take from which system or philosophy when we're working with these kids. Okay. Let's talk just for a few minutes about screening, assessment, treatment planning. As I said earlier, neither can be considered primary. Both disorders have to be treated. Both disorders have to be addressed in terms of assessing them comprehensively. You know, the research shows that adolescents will tell you the truth about their drug abuse or usage if they're guaranteed confidentiality. So the bottom line is, ask. And when you do ask, expect to find a co-occurring disorder, because it's much more common. It's fairly common, in fact. So in terms of an assessment, and right now I'm addressing mental health providers, you would do your standard comprehensive biopsychosocial assessment, but then also address the issue of substance abuse disorder using a brief screening tool is what we're recommending. And that would be for all adolescents entering the system, not just children that you suspect have a substance abuse disorder. If there is indeed substance abuse disorder, substance abuse usage, then we're recommending you follow up with a comprehensive assessment. And there are many, which we'll go through. And finally, we assess for trauma victimization, and again, I would expect to find it. In terms of treatment, we're recommending incorporate empirically based treatment for co-occurring disorders, and there are indeed many, much more so than one would expect. There's a lot of work being done now on this area. Target the most common comorbidities, and these would be the issues that the internalizing versus the externalizing. Go after those that are the most common and treatable, very treatable. And consider medication. Medication has a place in treating these disorders, particularly the internalizing disorders. So when you're doing an assessment for substance abuse, very straightforward, not anything you don't already know. the age of onset, which, by the way, is often around the age of 10 or 11, how it's progressed, what are the patterns of usage, look at frequency, look for tolerance and withdrawal, and look for triggers. Look for multiple drugs, polypharmacology, and ask what are the consequences, what has happened as a result of your drug usage. And then assess for motivation for treatment, and we'll go into how to do that later on. And ask about the family. You know, if there's extensive family usage of substance abuse, that is a prognostic indicator that it's going to be a much more difficult treatment issue. If there's a family culture of substance abuse, it makes it harder. Okay? So the instruments we're going to present to you are certainly not all of them. There's a lot of instruments out there. And we've attached some websites that will give you ability to look at these instruments as well as other ones. So these are the screening instruments that we think you might want to think about looking at in terms of using as part of your intake assessment. I'm not going to describe them at this point because of time limitations. The one I want you to think about looking at is the Global Assessment of Individual Needs short version, and we're attaching a sample. This instrument is part of a 2-hour psychosocial assessment that is being used in the CSAT sites, and it's been normed and validated on adolescents. And this this short version is a 3-minute screen. It's very practical, very straightforward, and I think you'll like it. We will attach a copy of that. Then if you need to go past the screening instruments, or if you want to just put in checklists, I know you're familiar with all of these. They've been around for a long time, and probably you're already using some of them. If you do find a substance abuse disorder or usage and want to move to a more comprehensive assessment, these are some that we recommend. I particularly like the DICA, Diagnostic Interview for Children and Adults. This is normed on and comes directly from the DSM-4 TR. So it's good in terms of a clear diagnosis. But these are all good assessment instruments. Okay? And again, just a few things in terms of assessment. Look for trauma. Expect to find co-occurring disorders, and consider when you're forming a treatment plan, after you've done your assessment, consider treating both disorders, not just the mental health disorder. Okay? So what about treatment? This is what we're here for. You know, this is our Rorschach slide. There it is. Here it comes. We're having technical difficulties here. You know, all of you, I'm sure, and all of you know about evidence-based treatment, and you know the principles of evidence-based treatment, and you know why we're moving to evidence-based, empirically grounded treatment. So I am not going to replow a field that you've probably spent a lot of time working on. So this is just a brief reminder of why we're moving towards evidence-based treatments. And all of the treatments that we're going to present to you are empirically grounded, evidence-based, for this, specifically for co-occurring and/or substance abuse and mental health problems. So you know, I've broken these into these categories, and this is an arbitrary grade. Many of these treatments overlap with the other, and have components of more than one. So this is that, but this is the way I thought that it would make the most sense to you. Okay, let's go to the next slide. This is a list of the treatments that we've looked at. Many of them, I'm sure, are very familiar to you. Adolescent Transitions Program, ART, Brief Strategic Family Therapy, Family Behavior Therapy, Functional Family Therapy, Motivational Interviewing, which is obviously not a treatment, but something that is proving to be extraordinarily helpful, both in terms of engaging people in treatment for substance abuse as well as for mental health disorders. So the next multi-dimensional family therapy, again, that's a very popular treatment, very effective, and a lot of development teams going here in the state with this. Multi-dimensional treatment foster care, which I'm sure you know of. And of course, MST, multi-systemic therapy. Seeking Safety, a trauma-based program. Strengthening Families, and the integrated co-occurring treatment. So those are the disorders treatments we're going to present to you. What I want to stress is this is not a comprehensive list. All of these are empirically grounded. They are, in the literature there is a distinction between some treatments that are listed as effective with co-occurring disorders, and then treatments that are effective with mental health and substance abuse disorders. It's a very fine line, and probably an arbitrary line, but I'll note those that are specifically marked as effective with co-occurring disorders as we go through these. So I started with family therapy. Present focus, pragmatic, family change. Pretty straightforward information there, something you all know. Individualized. There's a lot of research now for most of these, the base for these treatments we're going to present to you. Next slide. Let's look at the first one, family therapy, brief strategic family therapy. Excuse my paper rattling. And again, most of these I'm quite sure are familiar to all of you. And we've taken just brief descriptions of them. There's far more information available about any of these therapies. And I strongly urge you to go to the website. We will present all of the websites for you so that you can look at them. But anyhow, brief strategic family therapy targets adolescents 8 to 17, improves family interactions, a well-researched, well-established treatment paradigm. Behavior problems, reduced marijuana use, reduced association with antisocial peers. The client retention, I think, is very important. And the bottom line, improves family therapy, or family relationships. Primary target, severe conduct disorder and substance abuse. And I should clarify that in some of the research only does not consider conduct disorder as technically as a mental health disorder, and some of the research does. So we have placed in this list those therapies that do target conduct disorder, and we are considering that a co-occurring disorder with substance abuse. So, okay, family behavior therapy. Again, family therapy. Family behavior therapy is one of the treatments that is listed on the website for the National Registry of Evidence-Based Practices as being specifically effective for COD, co-occurring disorders. It's a very effective treatment. It's behaviorally based. As you can see, it looks at drug abuse and alcohol along with specific disorders such as depression, family problems, school, the behavior disorders. Okay. Very behaviorally oriented, behavioral contracting, skill-based interventions, skills training, communication skills. Okay. Adolescents 13 to 17. Tested across many ethnic ethnicity. So it's a very this is family behavior therapy, very practical, very effective. University of Nevada, and this is how you can contact the folks. I strongly urge you to take a look at this one, the family behavior therapy. Now, you don't have to say, if I stumble over these, bear with me, because between FBT, FFT, MDST, MTWD, I feel like alphabet soup occasionally, but functional family therapy. Again, targets youth in the age range 11 to 18, substance abuse and conduct disorder. Now, this is another extremely effective treatment. The interesting thing about functional family therapy, and I don't know if this holds true for the other family therapies, is that the functional family therapy seems to make a very large impact on siblings. So it truly is more of a treatment that is effective with the entire family. And as I'm sure you know, the functional family therapy is here in California. There's a lot of work being done on this. California is the largest implementation site for functional family therapy. I think in the States. So there's a lot of this gearing up and getting ready to go. Okay. Okay. Yeah. I put a little bit more information in about functional family therapy because I thought, because much of it going on here in California, I thought you would probably be interested. Small caseloads, well, I don't know, 12 to 15 families, depending on the families, could be a really big caseload, but a circumscribed caseload. A fair amount of training, certification and training to bring this functional family therapy in. Okay. Now this family therapy, under family therapy, the integrated co-occurring treatment model, this is a fairly new treatment. It is not listed yet as an effective treatment, although it is listed as promising. A lot of research being done on this, and it holds, I think, great promise because it's specifically targeted for co-occurring disorders, and it uses a model, a home-based intervention using the system of care philosophy. But the interesting thing about this treatment is that a single provider is trained to address both the mental health and the substance abuse needs. ICT uses motivational interviewing as a strategy. There's a lot of work about the community readiness, and this is melded with the intensive home service delivery consistent with wraparound. Do you love the flexible work hours, to be on call, 24/7 availability? That would be hard, but what it takes. Time limited. Most of these treatments are time limited. Small caseloads. I'm not sure what they consider a small caseload, but I urge you to take a look at ICT. I think it's we're just going to be I think it's going to grow most. So then we have multidimensional family therapy, MDFT. Again, this is another treatment modality that's fairly popular here in California and growing. Direct targets of adolescents with drug and behavior problems. As you can see, it's pretty good in terms of follow-up and improving drug usage. This is what I think is interesting. They are stating stronger outcome with co-occurring disorders when compared to straightforward cognitive behavioral treatments. There's some research, which I didn't have time to put in here, about cognitive behavioral treatment, and that it is very effective with adolescents. And if the MDFT is having a stronger outcome, that's very impressive. That's very impressive. Next slide. As you can see, they're saying superior outcomes as well to family group therapy, peer group, and residential treatment. University of Miami. Back up a second. I just wanted to say it's coming out of the University of Miami, and there are here in California, as I said, some training sites going using MDFT. Okay. And of course, everybody knows MST. I won't spend a lot of time on MST because I know you're probably familiar with it and have heard a lot about it. I want to note that MST is another of the therapies that is marked by the National Registry of Evidence-Based Practices as being effective specifically with co-occurring disorders. Having said that mouthful, you know the targets: chronic violence, substance abusing adolescents at high risk, decrease in substance abuse and use, 25 to 70% reduction in arrest rates, reduction in out-of-home placement. And I won't go through all of this for you. Next slide. I'm sure you've heard a lot about it. It's a very effective treatment. It's just the MST is what do I want to say? It's intensive services and labor intensive, and I think it's difficult for some folks to bring in because it can be very expensive, but it is effective and does work. So I think you just have to balance those two things. This is the website, by the way, for the National Registry of Evidence-Based Programs and Practices, and as I said, we'll have an attachment that has all these websites for you. Where am I? So those are the family treatments. Family treatments with adolescents is probably the treatment of choice. And many of the treatments that I have listed as cognitive behavioral treatments are family therapy as well. As I said, my grouping is somewhat artificial, and there's a lot of crossover. The point about cognitive behavioral treatment is it's brief, it's time limited, it's didactic, it's structured, and very effective. Okay. Now, I put ART, aggression replacement training in, even though it's because ART is primarily directed towards conduct disorder kids and probation kids. I still think that it's an appropriate treatment to put in this context because it does target those kids that are involved in drug abuse as well as antisocial behaviors, and it's effective.
I won't spend a whole lot of time on ART because I'm betting a lot of you know all about it. Again, here at California Institute of Mental Health, we're leading a lot of development teams, that are training folks in, I'm blanking on the name of it now, but it's very similar to ART. It'll come to me in a minute. But it's been around a while. I think you've all heard about it. I think you all know what it is. So again, I won't belabor the point. I'm going to go to the next one. It's broken into three components: the anger management, the skills training, and the moral reasoning. Group process. Right, we'll go to the next one. All right, so I just want to say about ART. I think that it's appropriate to be here. I think that in this grouping, I think that it's effective with drug abusing kids, and I think that it has a place in your repertoire. And I would consider using it if you're looking for something along those lines. Cognitive behavior under seeking safety. Again, this is not a treatment that could be, I'm kind of artificially forcing it into the category of being a cognitive behavioral treatment. But this is another one of the treatments that the National Registry designates as effective specifically with COD. Seeking safety primarily targets those with a history of trauma and substance abuse. It's psychoeducationally based, targets adolescents and young adults as well as adults. Again, we talked about how much trauma there is in the background of these kids. This is a good program if you want to be looking at dealing with trauma-related symptoms. So this also targets substance abuse and increased treatment retention, keeps people in treatment. Here's the website again. Here's the listing of it as an effective treatment. And then parenting programs. And again, I want to stress that the treatment programs we just went through are clearly not a comprehensive, all-encompassing list. There are many more. So let's look at a couple of parenting programs. Adolescent transitions. This is primarily for probation kids. School-based, family meetings, based on, again, social learning theory, skill development. Reduces interactions, negative interactions, antisocial behavior. Smoking. Now, you might say, why waste your time with smoking when there's all these other drugs? The research is saying that if you're able to target one addiction or abuse, substance abuse, and bring it down, the skills you learn, bring it down, I mean either eliminate or reduce usage. The skills that are learned are transferable to other substances. Another parenting program that is very effective is strengthening families. Younger kids, 6 to 12. This is for children of parents who have drug problems. Improves parenting skills, social behavior, family relationships. By up to 2 years longitudinal, I'm referring to the research following it, and it's doing quite well. Now, it's being adapted for the older kids. The research is still out on how effective that is. And again, it's skill-based, cognitively behaviorally oriented, and coming out of the University of Utah. Now, this is a very, very interesting a substance abuse treatment. I know we're talking to primarily mental health workers here, mental health systems. and it's not common in most mental health settings to do substance abuse treatment. But these are some new treatments. There's several of them. I thought you'd be most interested in the treatments of motivational enhancement therapy and cognitive behavioral therapy. So this is tested primarily with cannabis users, marijuana using adolescents, but it is transferable to other substance abuse disorders. And these are brief treatments. They're 5 or 7 sessions. They're manualized. There's a totally complete manual. Go back one. I forgot something. It's a combination of individual motivational enhancement therapy, in other words, engagement in treatment, and then a very brief cognitive behavioral component for treating the substance abuse. So 5 sessions, a 5-session model or a 7-session model. Okay, go to the next one. These are free. They're on the website, the Cannabis Youth Treatment Series website, and they're very effective. The folks at SAMHSA, who I talked to about these, are saying these are treatments that you can drop right into a mental health setting. They're not difficult to do. Motivational enhancement is very straightforward. The cognitive behavioral session is very straightforward. And I would like you to really think about maybe incorporating these into your treatment program. There are more on the website, which is there, we'll give you. But there's one based on MDFT, and there's another one based on community, I can't think of the name of it, community involvement. But the MDF, the manualized brief treatment based on MDFT is a little bit more complicated and probably would need more training and skill building before you would want to start doing it. These two, this brief 5 and 7 sessions, is easily transportable. And as I said, it has the added benefit of being free. Okay. So let's talk a little bit about motivational interviewing. You know, it's not a treatment, but it has a huge amount of information now in terms of settings it can be used in. It's what's the word I want to say? I think that those people who are using it and who are familiar with it are saying it's very, very effective in terms of engaging people in treatment and giving you something to work with when you have someone who is just not ready to do treatment. It's based on a theory of change, that change is a stage phenomenon, and that you have to work through each one of these stages with someone who is not willing yet to engage in treatment. As I said, been used in many, many formats and modalities, and I'm hoping you'll take a look at it in terms of engaging your adolescents. Their kids are hard to treat. I mean, we know that. It's just really hard. And sometimes this is a way to hook them, get them talking about why they don't think they need to change and why there's nothing wrong. So we've included that. We did the website. If you want more information, there's lots of information available about motivational interviewing. Okay. And lastly, out-of-home care. I'm guessing that all of you have heard of multidimensional treatment foster care out of Oregon. There is several training sites here in California. It targets kids with delinquency. A family-based program, an alternative to group home placement and or incarceration. It's good outcomes, very good outcomes, both good outcomes in terms of drug usage and improved emotional functioning, emotional well-being. Okay. Again, the youth is placed in a therapeutic foster home, 1 youth per home, 24/7, individual therapy with the problem-solving skills, the social skills, cognitive behavioral components, a lot of treatment, a lot of structure, a lot of support, really intense treatment modality, and highly effective, very effective. Okay. Rules. There's an individual therapist, a family therapist, skills trainer. Very structured. There's a lot of evaluation in terms of weekly follow-up, a lot of forms to be filled out, but while it's labor-intensive, it's very, very effective. And an alternative, a good alternative.
I think they gave it.
Can we stop for a second, regroup, grab my papers, make sure? Should we unmute for a minute to see if everybody's, if we're having any serious technical difficulties or, yeah. So unmute for a minute and give us a little feedback if you're hearing okay, if we're missing anything.
I think it's working well once I got the little program installed.
Good, good, good. Sounds okay?
Yeah.
Yep. Good, 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 good. Okay.
Can I ask a question since we're offline for a second?
Sure.
I see that there's somebody else online from my county, Santa Barbara County, without a name. And I'm wondering who it is so that we can collaborate on this training.
You know what? Send us an email because we have a roster, and we can email you back and let you know who else signed up from Santa Barbara County.
All right, very good. Thank you.
Okay. Okay, let's, if you'll mute up again. Ready? Okay, so let's look at recommendations. Let's get to the bottom line here. Okay, so what we're recommending is, and we need some folks to mute up again. *6. Okay?
This wasn't very good.
Thank you. Would you push *6, please? Okay, let's go. Recommendations. We're recommending that you use an assessment format that, in addition to your comprehensive biopsychosocial assessment at intake, that you add a substance use disorder instrument, a screening instrument for all adolescents, and then a more comprehensive instrument when it's indicated, when you see some red flags. We're recommending the GAIN short form. We've talked with SAMHSA, and although it's copyrighted by the Chestnut group, there is a way for us to be using it in California, and if anyone's interested, we'll work that out with you. Then we're recommending for the more comprehensive screening, the Adolescent Diagnostic Interview, or the DICA, which I like a lot. For family treatments, we're recommending the 3 family treatments that are listed by the National Registry of Evidence-Based Treatments as effective specifically to co-occurring disorders. The integrated community treatment, which is at this point still a promising practice. The multidimensional family treatment, which is very popular here in California. And multisystemic family therapy, multisystemic treatment therapy. In terms of a preventative program, we're recommending Strengthening Families, which is we're recommending Strengthening Families. For out-of-home care, we're recommending multidimensional treatment foster care. For social skills training, the aggression replacement therapy treatment. And for substance abuse treatment, we're recommending that you look at incorporating principles of motivational interviewing and that you think about these new treatments that combine motivational enhancement and cognitive behavioral therapy. A very brief treatment, but very useful. For trauma-specific treatments, we're recommending Seeking Safety. These are our websites. A bazillion websites. If you use these websites, you'll find far more information than you can possibly deal with. And as well, we've put on here all the websites of the treatments that we have gone over in this interview, or in this presentation. Next. So if you have any questions, if you would just send them to us in email format to Maria Lovato. And we're going to catch our breath a minute and then open up and ask you to have some discussion with us and some questions. Okay. Okay. Would you unmute and give us some questions? Or comments? No questions? Or comments?
It's a great presentation.
You're very kind. Thank you. We moved fast. As I said, there's a lot more information out there than we were able to present in this brief presentation. Any questions or comments?
Is this all state of California?
Yes.
I'm just wondering about if you have any thoughts about utilization of NORA funding if it passes.
No, maybe there's someone in our audience who understands NORA. I don't know anything about it. Is there somebody out there?
The Nonviolent Offender Rehabilitation Act that allocates $65 million for adolescent treatment.
Wow. Is there an expert in our audience that knows more about this? We can't hear you. I'm sorry. We speak up? Hello? Okay. Does anybody out there know anything about NORA?
Don't you? No, I don't. Okay. Come back after you've used it.
No?
I mean, they're just really overthinking addictions, you know.
Are you talking to us, or is that a background conversation? Hello? Speak to me.
Hello? Hello, I do know something about the NORA effort.
Good.
Robert Smith from Rebecca Children's Services. The NORA is the equivalent of the MHSA.
Oh.
It's on the ballot in November, and it's an effort to get voter approval to tax high earners to fund drug and alcohol treatment.
Desire to get clean, or how it's affecting their life, or get sober, and families and all that.
Is this an initiative that it will be on the November ballot?
Yes.
Yes.
It's going to be on the November ballot.
Will this money be funneled through? How's it going to be dispersed? Mental health or
alcohol and drug programs?
Alcohol and drug programs.
Huh?
Wow.
Yeah, it's the equivalent of the MHSA, so hopefully they find a better way of funneling it.
Mm-hmm. And then, do you know what the chances are for passage of this?
They're saying it's pretty good.
And
as I understand it, there are a lot of planning committees involved, including at the state level. And, the adult part of the system has a lot to do with criminal justice, but really no one's spoken very much about the adolescent piece. And that's really why I posed the question.
Mm-hmm.
I know a lot about the adult piece, but I'm not hearing about statewide planning groups for the adolescent piece. And I mean, this training is wonderful, and it seems like with this amount of research-based, outcome-based treatment solutions, it seems like something more should be going on organizationally at the state.
Yes. What I think should be happening, or hopefully will start to happen, is that in terms of the MHSA money, that looking at these programs that are effective with co-occurring disorders, it seems to me it should be part of the current phase of the MHSA, which is the preventative early intervention. I think you can make a very strong case that early intervention with whenever there's any kind of substance abuse starting to emerge can make a huge difference in terms of outcomes. And I'm surprised that there isn't more
early interventions.
Yeah, I'm surprised that the money isn't going to these kinds of programs.
Intervening. A lot of parents go, no, it's not happening.
No, And you know, I went really rapidly through the research, but there's really a lot of research showing that substance abuse really if you intervene early, you can ameliorate it, even with a major mental disorder such as bipolar or schizophrenia.
So what's this in your room?
And that's in the research you presented today.
Yes, and can you go to the attachments?
The sheriff's department. I need you to come out. My kids talking.
Let's see, because I think we have a slide that shows.
There's a knock on the door. Yeah.
It might be the slide. We need somebody to mute, or somebody who's talking to someone at the door. I think perhaps it's a slide in the presentation that shows the difference between the onset of the psychiatric symptoms and the onset of the substance abuse disorder.
To tell him what he's up against because
Is this the same as the PowerPoint you sent us?
Yes.
And what slide number is that? I can find it.
It's in the PowerPoint.
Make sure it's asleep.
Slide 3 or slide 4, I'm not sure which one. Is there anybody else have any questions or anything we need to expand on, because we moved very fast trying to cover a lot of territory?
Quite good.
This is Patricia Taylor, talking for Vince Giordano from the Family Care Network in Santa Maria, California. Can you hear me? Okay. I just wanted to comment on thank you for the presentation and including us. And it really does give us a wide range of knowledge on the way mental health is going. And I really like it because you're really beginning to include substance abuse with mental health disorders, which is something that's very, very much needed. And I just wanted to thank you.
Well, you're welcome. And again, that is the issue. This part of what this training is about is to try and move the thinking a bit to, you know what, you got to treat substance abuse disorder in the mental health setting.
You do, and not shy away from it.
Yeah, and not say, you know, come back when you're clean, or go see your counselor. And you have to look at developmentally appropriate treatments. A lot of the 12 steps are very, very effective, but often aren't going to work with adolescents who aren't ready for that level of autonomy yet.
Exactly.
Yeah. Okay. Anybody else have anything else we can talk about, or any questions?
Hi, this is Brett Jacobson from Riverside. Can you hear me?
Yes.
Yeah, I have a question. I don't know if you can answer this. And the out-of-home placement program that you recommended, MDFT, MPFC.
Alphabet soup.
Even I do that. You know, oftentimes you were saying that you got a lot of kids with co-occurring disorders. And MPFC is very prescribed.
Yes, it is.
In treatment. Do you know, because oftentimes there's a lot of cannabis use on the kids who come in, can you use this cannabis use, this program within MTFC or MTFC? Do you know?
You know, I don't know. I'm going to guess not, because the MTFC is pretty, as you said, it's a very prescribed structured program, and it would take. You know, I don't know for sure, but my guess would be it would be difficult to, given that they have everything so structured and organized, and they try and adhere very closely to their treatment model.
Yeah, they do, and we have this model here at the county, the MTC. So I was just wondering, because we've had so many kids coming in with severe cannabis use, I was trying to increase the likelihood of success.
Yes. I was just really impressed with these, and we talked to SAMHSA about them, these brief treatments, and there's 3 other ones on that website besides the 2 that I talked about. I was very impressed, and the fellow at SAMHSA, this is something that can be just dropped as a module into a mental health treatment center.
It's a different color.
And that just seemed like a very practical thing to me.
Yeah, I've seen the cannabis use treatment, and it's very user-friendly, I guess.
Very easy, and you can just download the manual and go and just set up and go.
Yeah. Okay. That was just my brief question. Thank you.
Thank you. Anybody else?
I have a question. My name is Brenda. I'm in Kern County.
Sorry, where?
The stars.
County Mental Health.
Uh-huh.
You talked about seeking safety. I would like to know how to get more training in that or get training in that.
Good for you. Seeking Safety, we've put the website, if you'll look at our attachments.
Amazing how they do it, you know.
It's in the presentation, and if you'll go to either the National Registry of Evidence-Based Treatments,
and now they're
so we're getting background from somebody, and there'll be a link directly to Seeking Safety.
Thank you.
Okay, I'm done with this conference. How about you?
Okay, can anybody else? Do we need to? No? Okay, I think we're going to end early, which is really always nice, especially when we're going into lunchtime. So if there's any questions that come up later, please email Maria. Everything will be on the website, including a longer presentation with outline with more information specifically about TAY, Transition Age Youth. And this will be recorded and downloadable. Thank you all. Thank you all very much, and good luck out there.
Yeah.
Email me questions.
Yeah, Joe?